Hi, I'm Dr. Lindsey Tavakolian. I'm a plastic surgeon. I want to share with you 5 key elements of my meticulous approach to facelifts. So let's talk about the skin first. My approach to how I treat the skin in a facelift is going to be dependent upon the patient's anatomy. And this means how far do I undermine the skin in a procedure. So in a facelift, there are really 2 main approaches to what you do with the skin. There's what you call a composite flap, where you elevate the skin just enough to achieve your goals, but you leave it connected to the deeper tissues in a large surface area of the face. And the second approach is to undermine the skin almost in entirety of the surface area of the facelift. So in a composite facelift, the skin is undermined really just right here in front of the ear, and then it's left fixed to the surface of your underlying structures here. And then the skin always has to be undermined across the neck. So these 2 techniques, oftentimes surgeons will pick one and then rigidly adhere to it. If I can get a good result with a composite, not undermining the skin all the way, then I'll do that. But if the area around the mouth, the jowls, is not affected enough by that lesser undermining of the skin, then I will extend my plane of dissection and I will dissect much further. Essentially, it no longer is a composite facelift and it turns into a full undermining of the skin. That's my approach to the skin. This leads us to the next layer underneath the skin. So you have skin and then you have fat underneath, and then the next main layer is called your SMAS. This is the superficial musculoaponeurotic system. What does this mean? It's essentially a stronger, more fibrous, denser layer of your face that provides a lot of the integrity of the facelift. So back in the day when facelifts were done skin only, you'd pull that skin back and rely on just pulling the skin back to lift your face. Over time, techniques have been developed, and it's been noted that facelifts are much better, they're much safer, and they're much more natural appearing when you lift this SMAS. I lift this SMAS in one of a couple different ways, and again, it's driven by the patient's anatomy. The SMAS in each patient can be really variable. It can be thin in some, thicker in others, and so how I treat that layer is going to depend on what building blocks I have for my face remodel that the patient has given me with their anatomy. And this leads me into my next key element, because how you treat that SMAS is going to be inextricably linked with the plane of dissection. So you've probably heard the terminology deep plane facelift. That's a really big buzzword. The plane of dissection generally refers to whether or not you're going to stay dissecting just on top of this mass, or whether or not you're going to go deep to that and go underneath this mass in the deeper plane, which is tiger country. That's where your facial nerves live. When I can, and when I can do it safely, and I know it's going to give me the best result, I will do a deep plane facelift. When it's not the best choice for the patient, or when I know I can get a really fantastic result by working on that SMAS from the top down, then I will always choose that. So this concept kind of pulls together the SMAS and the plane of the facelift together. You can't really talk about one without the other. So the 4th key element of my approach to facelifts includes facial fat grafting. So as you age, you lose volume in your face, and some people more than others. When I perform my facial analysis before coming up with a surgical plan, I will always analyze how much volume loss you've had and what your goals are. If you have pictures of when you're younger, it's helpful so we know what your baseline was. We don't want to make you fuller than you once were, but oftentimes fat grafting will be that cherry on top that takes a good result to a really fantastic result. This can be done during the same day of your facelift if indicated, and other times it can be staged. It will depend upon that particular patient's goals and then also surgical limitations. The 5th key element of my approach to facelifts is going to involve a conversation about drains. So a lot of surgeons have a preset amount of time that they leave a drain in for facelifts in particular, and my approach is going to be dependent upon that patient again. So some drains come out the morning after surgery. Some drains will come out 5 to 6 days after surgery, and this will be dependent upon things that I observe in the operating room that lead me to think that this person will have more fluid. And the more fluid, the more swelling you have after surgery, the more you stretch out your skin, stretch out the result. And we're trying to do everything we can to keep that swelling down and the fluid down. So the decision about how long your drain will stay in ultimately will be made in the operating room, but it can be early as the next morning or a week later. You will notice that all of these elements of my approach to facelift are very patient-centric, and they don't adhere to a rigid dogma. They, in fact, have been synthesized from years of training and seeing the absolute greats in aesthetic surgery perform their facelifts. And I have taken the pearls from each person that I have learned from and synthesized them into what I think works the best in my hands and limits risks during the surgery and then also optimizes their outcome. Please leave any questions in the comments below and I will do my best to answer them.